Hi everyone, and welcome to 𝐸𝐸𝐻𝐿𝐴𝐻𝐿. In this series, we'll explore key cardiovascular topics that are frequently tested on the USMLE Step 1. If your exam is coming up soon, these high-yield videos will help you master essential concepts. Let's dive right in and ensure you're well prepared to tackle cardiovascular system questions on Step 1. Today we're going to dive into a high-yield topic for your USMLE Step 1 preparation, types of shock. This is a concept that the NBME loves to test because it integrates pathophysiology with clinical management, making it a must-know area for both your exams and future clinical practice. Let's break this down through several clinical scenarios that frequently appear on the exam. Let's start with a 43-year-old man who presents to the emergency department after experiencing 4 episodes of coffee ground emesis, indicative of upper gastrointestinal bleeding, likely due to peptic ulcer disease. His blood pressure is critically low at 70/40, and his pulse is elevated at 130 min. His extremities are cool to the touch, and he shows signs of poor perfusion, such as loss of skin turgor. These findings are consistent with hypovolemic shock, which occurs due to significant blood loss leading to decreased intravascular volume. In hypovolemic shock, the body compensates for reduced blood volume by activating the sympathetic nervous system and the renin-angiotensin-aldosterone system. These systems increase heart rate and contractility, constrict arterioles to maintain systemic vascular resistance, and promote renal sodium and water retention. Despite these compensations, the reduced preload, measured as decreased right atrial pressure and pulmonary capillary wedge pressure, limits cardiac output. The primary treatment is rapid infusion of intravenous fluids or blood products to restore intravascular volume, increase end-diastolic sarcomere length, and improve stroke volume through the Frank-Starling mechanism. This intervention is critical for stabilizing the patient and preventing further organ damage. Okay, another hypovolemic shock case in pediatrics here. Let's consider a 2-year-old boy who presents with severe dehydration after several days of poor oral intake and diarrhea. His blood pressure is critically low at 65/42, and he is lethargic with signs of poor perfusion, such as dry mucous membranes and sunken eyes. This scenario is indicative of hypovolemic shock due to significant fluid loss. In pediatric patients, hypovolemic shock is often caused by dehydration from conditions like gastroenteritis. The reduction in blood volume leads to decreased central venous pressure, reduced pulmonary capillary wedge pressure, and decreased cardiac output. The body compensates by increasing systemic vascular resistance to maintain blood pressure. However, if not corrected, the resulting tissue hypoperfusion can lead to metabolic acidosis, which triggers an increase in respiratory rate as the body attempts to compensate by blowing off excess CO2. Management involves rapid rehydration with intravenous fluids to restore intravascular volume and improve cardiac output, alongside careful monitoring of electrolyte levels and acid-base status. Now, let's discuss a 15-year-old girl who presents with severe respiratory distress, diffuse wheezing, and an erythematous rash after eating at a restaurant. Her blood pressure is dangerously low at 80/40, and her pulse is rapid at 130 per minute. This clinical picture is consistent with anaphylactic shock, a life-threatening allergic reaction. Anaphylactic shock is another type of distributive shock, but it is triggered by an IgE-mediated hypersensitivity reaction that causes the release of histamine and other inflammatory mediators from mast cells and basophils. These mediators lead to widespread vasodilation, increased vascular permeability, and bronchoconstriction. Hemodynamically, this results in decreased systemic vascular resistance, reduced right atrial pressure, and lowered pulmonary capillary wedge pressure. Despite the reduced preload, cardiac output may be maintained or even increased due to a compensatory increase in heart rate. Immediate administration of intramuscular epinephrine is the cornerstone of treatment as it counteracts the vasodilation, reduces airway edema, and increases blood pressure. Additionally, fluid resuscitation is essential to restore intravascular volume. Next, consider the case of a 78-year-old woman who presents with an ST elevation myocardial infarction affecting the anterolateral leads on her ECG. Initially, she is treated medically as she refuses percutaneous coronary intervention. However, on the 5th day of hospitalization, she suddenly develops severe dyspnea, hypotension, and raised jugular venous pressure without lung crackles. Shortly after, she loses consciousness and becomes pulseless, and resuscitation efforts are unsuccessful. This case represents a classic example of cardiogenic shock, specifically due to a left ventricular free wall rupture, a catastrophic mechanical complication of MI. Cardiogenic shock arises when the heart fails to pump effectively, leading to reduced cardiac output and systemic hypotension. In this patient, the rupture allowed blood to fill the pericardial space, causing cardiac tamponade, which further impaired cardiac output by compressing the heart and preventing proper filling during diastole. Hemodynamically, this results in increased right atrial pressure, increased pulmonary capillary wedge pressure, and profoundly decreased cardiac output. The rapid onset of these changes leads to obstructive shock, where the heart is unable to generate sufficient pressure to maintain perfusion, ultimately resulting in cardiac arrest. Immediate intervention, such as pericardiocentesis, would be required to relieve the tamponade, but the prognosis is often poor once the rupture has occurred. Our next case involves a 49-year-old woman with poorly controlled diabetes who presents with fever, dysuria, and right flank pain indicative of pyelonephritis. She arrives at the emergency department in a state of septic shock, as evidenced by her low blood pressure, which is 80/44, high pulse rate, and signs of systemic infection such as flushed skin and lethargy. Septic shock is a form of distributive shock that results from a systemic infection leading to widespread vasodilation and increased capillary permeability. The primary hemodynamic disturbance in septic shock is a significant decrease in systemic vascular resistance due to the release of inflammatory mediators like nitric oxide. This vasodilation reduces venous return, leading to a decrease in central venous pressure and pulmonary capillary wedge pressure. Despite this, the cardiac output is often elevated initially due to compensatory increases in heart rate and myocardial contractility. However, the high blood flow rate through capillaries leads to incomplete oxygen extraction by tissues, resulting in elevated mixed venous oxygen saturation. Management focuses on aggressive fluid resuscitation, vasopressors to support blood pressure, and antibiotics to control the underlying infection. Next, let's examine a 66-year-old man who presents with sudden onset chest pain and hypotension following an inferior wall myocardial infarction. Despite treatment, he remains hypotensive with distended jugular veins but clear lung fields on auscultation. This presentation is suggestive of obstructive shock, likely due to a pulmonary embolism or right ventricular infarction. Obstructive shock occurs when a physical obstruction impedes blood flow through the circulatory system, reducing cardiac output despite normal or increased cardiac contractility. In this case, the obstruction in the pulmonary circulation increases central venous pressure and may lead to increased pulmonary capillary wedge pressure if the left side of the heart is also affected. Cardiac output is decreased due to the reduced preload and inability of the right heart to effectively pump blood into the pulmonary circulation. Treatment focuses on relieving the obstruction, which may involve anticoagulation or thrombolytic therapy and supportive measures to maintain blood pressure and oxygenation. Our next case involves a 49-year-old woman with poorly controlled diabetes who presents with fever, dysuria, and right flank pain indicative of pyelonephritis. She arrives at the emergency department in a state of septic shock, as evidenced by her low blood pressure, which is 80/44, high pulse rate, and signs of systemic infection such as flushed skin and lethargy. Septic shock is a form of distributive shock that results from a systemic infection leading to widespread vasodilation and increased capillary permeability. The primary hemodynamic disturbance in septic shock is a significant decrease in systemic vascular resistance due to the release of inflammatory mediators like nitric oxide. This vasodilation reduces venous return, leading to a decrease in central venous pressure and pulmonary capillary wedge pressure. Despite this, the cardiac output is often elevated initially due to compensatory increases in heart rate and myocardial contractility. However, the high blood flow rate through capillaries leads to incomplete oxygen extraction by tissues, resulting in elevated mixed venous oxygen saturation. Management focuses on aggressive fluid resuscitation, vasopressors to support blood pressure, and antibiotics to control the underlying infection. So in summary, these variations in hemodynamic parameters are essential to grasp, as they not only help differentiate between types of shock, but also guide appropriate management strategies. The NBME and USMLE frequently test these concepts, so a thorough understanding will be invaluable both for your exams and in real-life clinical settings. In hypovolemic shock, there is a significant decrease in right atrial pressure or preload due to reduced intravascular volume, which also leads to a decrease in pulmonary capillary wedge pressure. This reduction in preload results in a decreased cardiac output as the heart has less blood to pump. To compensate, systemic vascular resistance or afterload increases, attempting to maintain blood pressure and perfusion to vital organs. In cardiogenic shock, the scenario is different. Right atrial pressure and pulmonary capillary wedge pressure are both increased due to the heart's inability to pump effectively, causing blood to back up into the venous system and the lungs. As a result, cardiac output is significantly decreased because the heart cannot generate sufficient force to eject blood. Systemic vascular resistance is also increased as the body tries to compensate for the reduced cardiac output by constricting blood vessels. Septic shock presents a distinct hemodynamic profile. Here, the primary issue is widespread vasodilation, which leads to a decrease in systemic vascular resistance. Right atrial pressure and pulmonary capillary wedge pressure are typically normal to slightly decreased as vasodilation and capillary leak reduce venous return. Interestingly, in the early stages of septic shock, cardiac output is often increased due to a hyperdynamic response, where the heart compensates for the vasodilation by pumping more vigorously. These detailed cases highlight the complex interplay of hemodynamic changes in various types of shock and underscore the importance of timely and appropriate interventions to stabilize patients and prevent further complications. This knowledge is critical for your exams and, more importantly, for effective clinical practice in acute care settings. Thank you for joining this episode of the Metacoccus video series. Stay tuned for more high-yield discussions on topics that frequently appear in your NBME and USMLE exams.